Hello, good evening. You're all very welcome. Thank you for joining us this evening for our fifth instalment in our six-part GP webinar series. I'm Tamara and I'm the Director of Communications and Advocacy with St. Patrick's Mental Health Services, and I'll be your host this evening. So tonight's hour-long webinar focuses on supporting those experiencing memory difficulties, So first, we're going to hear from Dr. Sarah O'Dwyer, consultant psychiatrist at St. Patrick's, who will give a brief overview of the memory clinic in St. Patrick's. And Dr. O'Dwyer is also going to focus on clinical issues and management issues that may arise for GPs in primary care relating to memory concerns. Next, we'll hear from Dr. Karen Looney, who is Principal Clinical Neuropsychologist at St. Patrick's. And Dr. Looney will discuss memory testing that GPs can undertake in their surgery to help guide their management of patients presenting with memory problems. Dr. Looney will also explore the difference between normal and abnormal aging. So following both presentations this evening, hopefully we'll have some time for a short question and answers with our two panelists. So you can submit questions throughout the webinar using the Q&A function at the bottom of your screens, and we'll try to get through as many as possible in our Q&A session. Just so you know, ICGP certificates, CPD certs will automatically be sent within the next couple of weeks. It could take up to 4 weeks to any GP who's registered and who is attending live this evening. So let's get started. Firstly, let me introduce you to tonight's first speaker, Dr. Sarah O'Dwyer.
Hello, good afternoon. Thanks, Tamara. So, okay, I'm going to share my screen. Okay, can everyone see that?
That's up there, yeah, Sarah.
Perfect, great, thank you. Okay, well, so welcome everybody. And tonight, our webinar is about memory clinic, and the main real focus of this topic is more to have a practical approach rather than an academic approach, really in helping to manage patients who present with memory or cognitive deficits in primary care. So what I will do is basically provide a very brief overview of some of the related or relevant topics. That'll include a clinical workup of a patient who presents with memory complaints or cognitive complaints in primary care. I'll discuss some of the important strategies that you can encourage patients to use who are presenting with memory deficits or even subjective memory complaints within a primary care setting. Then we'll explore some of the interventions that can be used when memory complaints are heralding something more sinister or more pathological, such as a neurodegenerative process like Alzheimer's dementia, and when it's appropriate or when you should consider referring to specialist services and the potential benefits of doing that when indicated. And I'll then touch on a few other clinical aspects that I think can often cause difficulty in primary care, particularly managing patients with dementia from a pharmacological perspective, also managing BPSD, behavioral and psychological symptoms of dementia, and then maybe it's some time just touching some of the medical legal issues that can arise, such as enduring power of attorney and capacity. So to begin with, I thought it might be helpful to give a brief overview of our memory clinic here in St. Patrick's. So our memory clinic is a multidisciplinary team assessment service, a comprehensive assessment service. It's set up initially by Dr. Declan Lyons, two consultant psychiatrists, myself and Dr. Lyons. Karen Looney, who's going to be speaking later, is our principal clinical psychologist and neuropsychologist. And very shortly, we're going to welcome a very much needed second psychologist to the team. We also have an OT and a clinical nurse specialist. And we accept referrals basically from primary care, other physicians in clinical settings, and internally from our colleagues who have patients with memory concerns that are difficult to manage. We see patients across the spectrum of age, but the majority of patients obviously would be over the age of 60. So as I'm sure you're all aware, St. Pat's is very much an inpatient-based model of care. And so the comprehensive memory assessment really takes place over a 3-day assessment. On average, we see a patient per week for comprehensive MDT memory assessment. Patient is admitted on a Sunday. On a Sunday, they will have a full clinical examination, a full history will be taken. If bloods are not already available from primary care, bloods are arranged on Monday morning. And then the patient will meet with Karen on Monday and spend the majority of the day with Karen undergoing a full battery of neuropsychological assessment. If an AMPS, which is an assessment of motor and processing function, which is undertaken by our OT, if one is required or indicated, that will take place also on Monday or Tuesday morning. Collateral information is also obtained usually by our clinical nurse specialist. to have a comprehensive assessment as part of the comprehensive assessment. And then on the Tuesday, we meet with the patient, we interview the patient, and we examine all of the difficulties that have been reported or that the patient is reporting. The patient then returns home, and what we do is we devise a time where a comprehensive feedback session takes place, and this is usually within a week. And in the intervening period, what we do is we allow that time to collate all the information available and to have a multidisciplinary meeting, which is a consensus meeting to allow us to use the information that includes the history collateral, blood tests, neuroimaging, and the results from the neuropsych assessment to inform really what is a consensus diagnosis, and then devise a comprehensive plan. And we then meet with the patient and the family and we feed that information back. So just to mention, along with the pandemic, it kind of heralds really a change in the way in which we do provide the service in an effort really to ensure that we could continue the service during lockdown. So while previously all admissions would have been physical and face-to-face, on certain occasions where a patient was suitable or where the supports at home facilitated it, we also now provide virtual admissions or a home care package. But again, it's very much individual case-by-case basis whether that's suitable. What we have continued to do while most of our admissions now have returned to physical admissions is that the feedback meeting that takes place the following week is often done virtually, because it allows family members who previously wouldn't have been able to attend because of other work commitments very easily just log into Microsoft Teams and attend the meeting. Okay, so then returning to primary care, and which is the focus of tonight's talk, and how to manage the difficulties that can arise when someone complains of memory or cognitive deficits in primary care. So we all know that, and I'm sure you're all very aware that sometimes diagnosing dementia or memory deficits in primary care setting can be very difficult. And often one of the main issues is being able to identify or differentiate between what is normal aging versus what's basically symptoms of dementia. Now, I won't focus too much on that because Karen is going to cover that extensively in her presentation. But really, patients are going to present at some point along the memory trajectory or pathway from subjective memory complaints. And a lot of the times we will get patients, high functioning professionals, who towards kind of retirement age start to become more worried about their memory, forgetting names, misplacing items, but then finding them. Often they present to GPs concerned about their memory too. And it's very important at an early age to detect those and to, I suppose, address those issues. Often there's nothing to be concerned about, but basically empowering a patient and, advising them about strategies to help improve memory if they're finding that they're becoming a little bit more forgetful. Then there is going to be a cohort of patients that present with mild cognitive impairment. So mild cognitive impairment, there is evidence, objective evidence of deficits, but where the ability, the functional day-to-day ability is preserved. And mild cognitive impairment, is divided kind of basically broadly into amnestic mild cognitive impairment, non-amnestic mild cognitive impairment, and multi-domain. Now, Karen will focus more on this, but just to highlight that in amnestic MCI, really it's the memory domain where there's evidence of deficits. And again, that's more clearly seen in kind of an Alzheimer's picture. Non-amnestic MCI is where the memory is often preserved, but the deficits are occurring in other domains. So complex attention, executive function, motor and perceptual functioning, and kind of social cognition. And multi-domain MCI is where you're getting deficits occurring throughout or across the domains. It would be helpful if we could do the poll now, Sinead. The first poll, which is how many patients per year do you see who complain of memory complaints? And also the second, how many patients per year do you actually diagnose with dementia? So while you're responding to that, I'll just mention that, some patients are going to present with an established, evidence of dementia. And dementia is really a global term at this stage, an umbrella term for a large variety of conditions where there's a decline in cognition, often across a number of cognitive domains, not just memory, but other cognitive domains. And where this decline, there's evidence that this decline is basically a change from the past. But not only that, there's evidence that it impacts on day-to-day functioning. And when I say that, instrumental activities of daily living are basically impaired. So things like being able to manage medication or being able to pay bills, etc. Okay. Sorry, Sinead, I think I might be stuck. Okay, so how many patients do you see with memory complaints? Less than 10. Okay, so it's an even. Okay, so it's kind of a third across. Okay, and interesting. Okay, over a third see over 20. Okay, that's really interesting. And then how many patients diagnose? Less than 5 to 10. Okay, that's what I was in keeping with what I would expect. I mean, most of the research would suggest that on average GPs would kind of see between maybe 1 to 10 or less patients with memory complaints. And then there's obviously a portion that see more. So I think that is an interesting finding. It would be interesting to know how many also you refer on to for more specialist assessment. Okay. So Sinead, I think I'm stuck.
For sharing the screen, is it, Sarah?
Yeah.
I can see your screen up there now.
Okay. Oh, there we go. Perfect.
Yeah.
Okay. So then just moving on to the clinical workup in primary care. So, you know, when a patient is coming in and a family member or a patient comes saying, listen, I've got memory complaints, or I'm becoming forgetful, I can't remember names, I'm misplacing things in the house, and I'm concerned about it. And you want to do basically kind of a clinical workup. Where do you even begin? So cognitive testing, I'm not going to talk about because Karen is going to discuss that extensively in her presentation. So what I'm going to focus on are the other investigations. Okay, so the first of all, basically, obviously you're going to do, you know, a full history examination, etc. But looking at blood, so the first thing, what you're trying to do is to identify if there's any reversible causes or basically clinical issues that are going to be mimicking or leading to cognitive deficits or memory concerns. So the routine bloods that we would always order for our patients, again, you know, FBC, UNE, LFTs, TFTs, ESR, fasting glucose and lipids, again, looking for reversible or cardiovascular risk factors, bone profile, a vitamin D. I mean, just to note, I know vitamin D isn't recommended to be done routinely as part of screening, but I think when you look at the kind of higher risk cohort of patients, it might be worth considering. More recent research has shown, published by King's College in London, following a cohort of patients who had low vitamin D levels, that after 10 years, they did have progressive cognitive deficits, something that's very easy to replace and something that you often find is quite low, particularly in nursing home patients. I've just put VDRL and HIV in brackets, again, obviously not routinely indicated, but if you have a patient who's presenting and there's history and potential risk factors in their history, it may be worth considering checking for that. I mean, again, neurosyphilis and HIV dementia are quite rare, but also to consider it if the history indicates it. MSU, I only mentioned that just from the point of view that if someone is presenting with acute memory concerns, obviously to rule out that there's no UTI or sepsis, particularly in older adults. The other thing too is, you know, constipation causing a delirium, etc. ECG for baseline, again, with someone with any type of cardiovascular risk factors, and particularly as well, while it's not, you don't have to, I think it is good practice before you start a cholinesterase inhibitor in someone with established diagnosis of dementia to have a baseline ECG just to make sure that there's no evidence of second or third degree heart block. It's not contraindication first degree heart block, but it is in the alternative too. So having a baseline ECG is helpful. And then I wanted to just focus for a moment on neuroimaging. So if a patient is presenting with cognitive concerns that you feel warrant investigation, scanning their brain is important and should be undertaken. And really the aim of that is to identify if there's organic pathology that's reversible, such as a space occupying lesion, versus looking for evidence of neurodegenerative changes occurring within the brain. So particularly in older adults, it's going to be more beneficial in supporting your diagnosis. Adults over the age of 85, they're going to have age-related atrophy anyway, so it doesn't necessarily contribute as much as a scan in a younger patient. But nonetheless, if you feel it's indicated, it is important to do it. And in relation to the neurodegenerative changes, you know, the question is CT versus MRI. I know CT is much faster, but its spatial resolution is much poorer. And while it will give you, you know, on your report, you will get, you know, it'll highlight whether there's global cortical atrophy. It's not really good at identifying whether there's vascular loading. So that's deep white matter hyperintensities and deep white matter changes occurring within the brain. So an MRI is far more effective, and we would always in the memory clinic insist that an MRI has been completed, obviously if that's clinically possible and the patient can tolerate an MRI. So again, what you're looking for is global cortical atrophy, disproportionate atrophy, which is frontotemporal atrophy. Okay, again, if you have any concerns with someone who's presenting with more frontal deficits, temporal hippocampal atrophy, and as I said, vascular loading. And really what's very important is what you ask for in the request will really determine, you know, the quality of information back. So just to give you two examples, the first on the left is basically, a report from an MRI that was requested with very little information provided, and there was no specific request for coronal imaging or for them to comment on the hippocampi. And so while, yes, from this information, you've no acute concerns about the individual, it doesn't really help to support any diagnosis of dementia. On the right-hand side is a request for a patient who was presented with early onset, what I believe to be Alzheimer's dementia. We specifically asked for T2 and FLAIR imaging. We specifically asked for coronal imaging and for the reporter to comment on the hippocampi complex. And as you can see, the quality of the report is far more comprehensive, and the information provided very much supports the diagnosis that you detect or that I suspected at the time. So as part of a memory clinic workup, it is very important. I've noticed over the years that if you do specifically request coronal imaging and ask for the reporter to comment on the hippocampi, because it isn't routinely done, and it's something that can be very helpful with the diagnosis. So then, GPs, of course, are very adept at diagnosing dementia and memory deficits within the primary care setting and undertaking the necessary workup. But at times, is there benefit from actually specialist intervention and referring on to a memory clinic? And I think on occasions there is, particularly with complex presentations. So that's individuals potentially with medical comorbidities, maybe a history of head trauma, or patients who are presenting clinically, but the cognitive testing and the clinical presentation are not necessarily congruent. They may benefit from a referral onto a specialist memory clinic. Also, subtyping of dementia. I mean, really, you need the value of neuropsych testing in order to be able to subtype dementia and to identify the specific domains that are affected. So particularly for, let's say, the more unusual types of dementia, like frontotemporal dementia, or even subtypes of that, such as PPA, which is primary progressive aphasia, that's not something that's going to be diagnosed in a primary care level, and it's going to require specialist service. The need for further specialist investigations, we often will request PET and on occasions CSF biomarkers. Again, if someone is presenting with early onset, a rapid acute deterioration, or if the clinical presentation and the clinical findings are not congruent. Signposting to resources can also be helpful for caregivers as well as patients, and also kind of facilitating specialist follow-up. Often patients with dementia are left really being managed in primary care with very limited supports, which can be very stressful for everyone, and having access to special services and additional, I suppose, management plans can be helpful for everyone involved. So then I wanted to just focus a little bit on some of the things that can mimic or some of the reversible causes of dementia that can be seen in primary care, and what is very important to detect and monitor in the primary care setting. So the three major mimickers of dementia are obviously drugs, depression, and delirium. So I want to focus mainly on drugs, but just to mention, obviously, with delirium is that, an acute confusional state that's usually metabolically induced. And is usually reversible. So it's very important if someone is presenting with an acute change to consider that. The other thing too, obviously, is someone who has an established diagnosis of dementia are more likely to develop a delirium, and patients who have repeated episodes of delirium are more likely to be at risk of cognitive decline and progression to dementia. So it's very important that underlying precipitants of delirium are kind of addressed proactively and robustly. Depression, particularly in older adults, is extremely important. It's very important to robustly treat depression in older adults. Depression in older adults is usually a melancholic or an endogenous depression. It often presents quite differently from depression in the younger adult cohort. A melancholic depression, a patient may not necessarily report that they're depressed, but they'll have the classical symptoms of diurnal mood variation, sleep disturbance, appetite loss, and they may often present with somatic features rather than actually saying that they feel down. So it's very important to robustly treat depression in older adults to prevent a pseudo-dementia. Then just focusing on medications and the major culprits for cognitive deficits, impairment in concentration and attention. So hands up, psychotropic medications play a significant concern there, particularly antidepressants, the older style antidepressants. So that's looking at the tricyclic antidepressants. Often patients are on amitriptyline for neuropathic pain. Even at a small dose, it can some have cognitive blunting effects. Patients who come to the memory clinic, we always recommend stopping it, particularly if it's like 25 milligrams, and consider alternative for pain management. The others are cholinergic drugs. antidepressants, even SSRIs, do have a cholinergic burden. The medication with the least cholinergic burden, which can be very effective in older adults with depression, is duloxetine. It's less likely therefore to cause cognitive deficits. The sedative medications, particularly the antihistamines like Phenergan in the older adults, is just not a good option. And as well, the longer acting benzodiazepines is also, they can cause problems. Opiate medications, obviously the highest risk is with pethidine. Corticosteroids, again, dose related. And also to be aware that statins, which is something people don't consider, but there's a growing evidence base that individuals with statins develop this cognitive blunting, poor attention, inattention, and concentration, which is reversible when the statin dose is either reduced or stopped. So again, it's about rationalizing and streamlining medications to identify if any medication that the patient is on, because we all know older patients have a tendency to collect medications over the years that often necessarily the original indication is no longer valid. And it's important to try and streamline those and rationalize those, which is what we always do as well when a patient comes to the memory clinic, and consider alternative options. Then just the medical conditions that sometimes play a role. Hypothyroidism, really important to detect that. Again, part of blood tests. As I mentioned, depression, very important that is addressed proactively. Again, depression in itself and repeated episodes of severe depression increase the risk of developing dementia in older age. Vitamin B12 deficiency, normal pressure hydrocephalus, again, not very common, but often patients in the early stages present with cognitive deficits before the gait and urinary incontinence become evident. Sleep apnea is a really important one. Patients with sleep apnea have pervasive hypoxic events. That leads to hyperperfusion. It leads basically to endothelial damage, and you get damage with the blood-brain barrier. And ultimately what you're doing is you're getting small vessel ischemic changes occurring over a very prolonged period of time, which will result in two things, which is one, vascular depression, and two, mild cognitive impairment, which can progress to dementia. So very important that is proactively managed, and they're referred to the appropriate respiratory services for the appropriate treatment. And then of course alcohol, which is a huge issue in Ireland, but managing alcohol, trying to get an accurate history of alcohol intake, and minimizing or eliminating alcohol, particularly if it's a concern. We also know that by eliminating alcohol, cognitive deficits can actually improve that had previously been associated with alcohol for up to 5 years. So when patients do present with memory difficulties, the important thing for all patients, irrespective of what part of the trajectory of memory difficulties they're on, be it subjective complaints up as far as patients who are presenting with dementia, is to basically focus on strategies that are going to help to improve memory. And so there's 7 key strategies that it's very important patients are informed about and encouraged to follow in their day-to-day life. The first is mental wellness, which is what I spoke about. And that's not just about having, robustly treating mental illness, but also trying to reduce stressors, engaging in therapeutic activities, psychological activities like mindfulness, etc., in order to reduce stress. We know that does help to improve cognitive and memory complaints in adults. Obviously, addressing what we call the modifiable risk factors, particularly robustly addressing cardiovascular risk factors, patient who's at risk, making sure that they're on the correct anticoagulant, statin, if it's not causing cognitive deficits, ensuring that those issues are addressed. Managing other chronic conditions like diabetes, chronic pain, anything that really increases their likelihood of frailty, which is, kind of an up-and-coming topic in geriatrics in general. Weight and dietary management is also very important in trying to establish a stable BMI. Diet is really about taking a healthy approach, kind of reducing LDL, increasing HDL, reducing the amount of sugar consumption. There's a lot of misinformation about diet and dementia, available on the internet. So it's about addressing or guiding patients to the correct and appropriate resources that are beneficial for them. The very important is also about exercising not only the body but also the mind. Okay, so we know that cardiovascular exercise, about 150 minutes a week, is known to reduce your risk of dementia. We also know that people who are runners, have greater perfusion to the brain, and they also have a larger volume for their hippocampi in general compared to non-runners, but also then exercising the brain. And that's obviously about preserving your cognitive reserve and also engaging in stimulating, kind of activities such as Sudoku, word puzzles, etc. But it must also be enjoyable. And it's very important that a person enjoys the activity they're doing so that they're likely to persist with it. Sleep is very important, okay, as I talked about the importance of actually getting sleep, because we know as well patients who have chronic insomnia are at risk of cognitive deficits and potentially dementia moving forward. And again, the importance of social engagement. And more recently, research has shown that it's not just important to socially engage with your peers, but intergenerational social engagement is actually more beneficial. So it's more beneficial to actually hang out with young people than it is to hang out with your peers. And that appears to have a protective effect also. So then just very quickly looking at management. So there is going to be patients who present who have an established diagnosis of dementia, or you make a diagnosis of dementia, and it's the next step along the trajectory of management. So when you've done all of the non-pharmacological interventions or offered all the support, but the patient is then the option of basically treating this with pharmacology. So obviously, the acetylcholinesterase inhibitors are what are licensed for the treatment and management of Alzheimer's dementia. And donepezil, rivastigmine, and galantamine, okay, are acetylcholinesterase inhibitors. They prevent the breakdown of acetylcholinesterase to allow an increase in acetylcholine, which is basically the neurotransmitter that they're, the theory is that that's deficit in people who are presenting with this neurodegenerative condition. And they do basically, between 40 to 70% of patients are going to notice a benefit within 12 months. The rationale really is that you try it for 12 months. If there's no evidence, if there's no benefit evident during that time, there's probably no benefit in continuing it. Some patients report not only improvement in their memory, but also in their overall mood. So particularly with donepezil, so it can be effective treatment and something to consider. With rivastigmine, I usually just, if donepezil hasn't worked for whatever reason, or particularly rivastigmine is very good for vascular dementia, particularly patients presenting with significant behavioral and psychological symptoms of dementia. Rivastigmine patch, it causes significant nausea if taken orally. So starting with the patch is often really effective, and then basically slowly titrating up the dose to the transdermal patch. And then from moderate to severe dementia, Alzheimer's disease, it's NMD receptor antagonist memantine, which works by reducing the amount of glutamate in the brain, which is considered to be toxic in Alzheimer's dementia. So again, while they're mainly licensed in Alzheimer's, we often use them in vascular dementia as well, though there's less obviously evidence-based, but sometimes anecdotally they do have benefits, particularly in BPSD. And then looking at BPSD, because I think a lot of GPs end up having to manage patients who are living at home with carer burden, and there's behavioral disturbance and really difficulty managing patients, and often patients end up resulting in kind of like long-term placement because of difficulties managing the behaviors, etc., as the dementia progresses. So obviously the first step is non-pharmacological interventions, and that's about addressing the home environment, looking at any of the factors that may be contributing to the behavioral outbursts or the distress, looking at the timing, looking at the environment, the individuals who are present, making sure sensory deficits are addressed, so hearing as well as visual sensory deficits, which we know increase their likelihood of BPSD. If pharmacological interventions are needed, the only one that is licensed really in BPSD is risperidone. So low dose risperidone. Sometimes patients do develop extra pyramidal side effects, and that are EPSEs, so cogwheeling, stiffness, rigidity. You can always consider quetiapine and also olanzapine, but risperidone really is the only one that is licensed. Trazodone, again, it's very much a mixed approach to that. I find trazodone very beneficial. I often use it for patients who are sundowning, and I find it very good. Some people report that they don't find benefit. Some patients respond and some patients don't. I wanted to just mention melatonin and temazepam, both because for sleep. So try to get patients off Z drugs if you can. Now, I know I mentioned temazepam because it is licensed for treatment of insomnia in BPST. It's short acting and it does get patients asleep and is metabolized quite quickly. So, the risk of hypertension is reduced with it. So I do use it when it's required and when other medications aren't working. But melatonin is also one to worth try. There is an evidence base for epilim and carbamazepine. I don't use carbamazepine because it interacts with too many other medications. There is an evidence base for it. And also with patients with very severe BPSD and behavioral disturbance and aggression, low dose epilim chrono, 200 milligrams twice a day can sometimes be effective. It's very much just a trial basis. And citalopram, irrespective of its antidepressant effects, is an evidence base for reducing BPSD as well. And then very quickly, because I know I'm almost out of time, just to mention enduring power of attorney. So just to say, I know this is something that often lands on the desks of GPs. Again, this is a legal document where someone who loses capacity is basically allowing someone else to take over that role, the attorney. And a capacity assessment is required, usually when it needs to be donated, not necessarily when it needs to be registered with the High Court. So sometimes that can be something that leads to an issue, but a capacity assessment is quite easy to carry out in that case. On-road driving assessment, any type of kind of visuospatial difficulties that are identified, family member coming in saying, their beloved mother is, multiple tips in the car, it's important that you recommend that. And these are just some of the resources. And then very quickly, just to mention some of the very beneficial resources: Alzheimer's Society of Ireland, great for caregivers; Dementia Ireland. Hello Brain is really good for patients because it's very interactive, a lot of really good videos. The Harvard Health Publishing online memory program is actually really good for patients who present with memory deficits. It's a really informative, very educational. It's about €30 to join, and you get online module. Definitely worth considering. And DBMAS Australia, just to mention for any GPs who are managing patients in nursing homes, this is the Dementia Behavioural Management Advisory Service in Australia, an excellent resource for behavioural management strategies for patients with BPSD in nursing homes. And I think I'm just out of time. Thank you.
Thank you so much, Dr. O'Dwyer. You did an amazing job at keeping the time there. It's just 8 o'clock. You packed an awful lot in there. So if anyone has any questions for Dr. O'Dwyer, we're hopefully going to have a few minutes at the end, just before 8:30, to take some questions. But before we do that, I will hand over now to Dr. Looney. I'll just ask you to unmute there and share your video. And I'll hand over to you there. Thank you.
Thanks, Tamara, and thanks, Sarah. That was really helpful. And thanks to everybody who's tuned in. So I'm just going to share my screen now. And if we can go from... Okay, so hopefully that's up on the screen there. Okay, so I'm Karen Looney, and I am...
Sorry, Karen, your presentation actually isn't up there.
Not up, huh? I wonder why that is. Let me try again. So
yeah, there you go.
That's it.
Okay. Let me just see if I can. Okay, so you can see it on your screen there. And is that working?
That's it. Yeah.
Perfect. Okay, thanks so much. So I was really interested to hear the results of the poll that Sarah did there, because it is very much in keeping, I guess, with other research showing that between about, GPs will typically diagnose between about 1 and 6 new cases of dementia each year in their practice. This is based on a survey that was carried out in 2018. But I guess, there was also an interesting piece of research I came across where they had done a screening of caseness in the US, and found that about half to 2/3 of patients who subsequently went on to be diagnosed with dementia had no such diagnosis noted in their medical notes at primary care. So, there's no doubt that this is an area that's going to increase. The demand for memory assessment is going to increase as the population ages. But also there may even be cases, on your books at the moment that are sort of unseen. So I just want to highlight a particular resource, which I think is excellent in terms of informing people about, when to be concerned and when not to be concerned, and gives very good reassurance and public health information about cognition and aging. And it's freedomliving.com. And this was a collaboration between Genio and the Trinity Brain Health Project. And they've produced these little short films about the brain and what happens as we age and so on. And there's other really, really helpful resources there as well. It's where you can access the Hello Brain app. There's a book you can download about 100 days to healthier living. And one of the all the films are done with kind of cartoon characters, and they're just a couple of minutes long. And there is one specifically for GPs. So I'm actually going to allow you to kind of kick back and grab the popcorn. And I'm going to show you that little film if I can manage to share my screen. So let me just try and get that ready. And I just want to make sure I do it with the share sound. There we go. Okay. So, okay, take a look at this.
I'm a doctor. Is there a good way to check out a memory complaint? No matter how experienced a doctor you are, you can't tell a patient's blood pressure without checking figures from a blood pressure test. Neither can you diagnose pneumonia unless you listen to your patient's chest. It's the same with someone who comes to you with a memory complaint. You can't draw conclusions about their memory function until you put some figures on it and carry out a brain health check. What does a brain health check look like? Well, there are 5 steps to remember when dealing with a person's memory. Number 1, know the history. Like with any patient, listening to their story is crucial. You need to understand the concerns, checking with family members where possible, to see if there's anything else that could be interfering with their memory. Step number 2, gather evidence. A brief physical examination and a blood test could pinpoint a treatable and even reversible cause for a patient's memory loss. Things like hypothyroidism or B12 folate deficiency. Number 3, give a test. A short cognitive examination puts a number to the problem, allowing you to make an informed conclusion. To assess their cognitive function, use pen and paper tests that evaluate memory, thinking, and reasoning. Step number 4, refer for a second opinion. Completing a brain health check should help clarify what's going wrong, but it can also reveal whether you're in a position to offer further help, or if it's best to refer your patient to a specialist for a second opinion. And that leads right to number 5, give advice. Whatever the outcome of their cognitive assessment, whether they have a memory problem or not, offer informed advice on lifestyle changes that they can make for the sake of their brain. Think of these 5 steps when someone presents with a memory complaint. These steps are good to know, especially when the number of people over 65 is rising and you're going to deal with more memory problems in the future, which all means now is the perfect time to add brain health to your patient checkup routine.
Okay, and let me just go back to my slides now. Okay, is that showing on the slide on the screen there?
It is.
Okay, excellent. Thanks, Tamara. Okay, so really what I wanted to do there was just kind of make you aware of that resource. And primarily what I'm going to be speaking about in my talk is this issue of cognitive screening in primary care. So step 3 in that 5-step process. And then I'm also going to talk a little bit about normal cognitive aging, so that we can have that in our heads when somebody comes into the GP, into your office, complaining of changes to their cognition or memory concerns, because often it's not well understood what normal cognitive aging can look like. And lots of older people will worry unnecessarily when they notice changes within themselves. Okay, so if we were thinking about a screening tool that you might want to grab in your office when your patient comes in, you know, there's certain kind of things we want on a sort of a wish list that screening tool is going to provide. So something with the ability to correctly identify dementia, but also to catch more subtle changes in cognition, the sort of mild cognitive impairment realm, and the kind of subtle changes that might cause people to worry. We definitely need something that's going to be statistically robust enough to do the job it's supposed to do. So to have the sensitivity to correctly identify when there is a problem, also the specificity to, you know, correctly identify, you know, negative cases when there isn't a problem. Ideally, if we can get something that has more than a cutoff, that's going to be much preferable. You know, cutoffs are kind of handy. It's one number, it's easy to remember, but it's very obvious if we think about it that, you know, a cutoff on a rating scale or a cutoff on a cognitive screener, you know, is not going to mean the same thing for an 85-year-old with a primary level of education and a 65-year-old recently retired college professor. So we need something that's going to be able to give us meaningful data across the whole range of presenting patients. Definitely need something that's going to be quick and easy to administer, something that's acceptable to a patient, isn't too distressing to complete, and ideally covers multiple domains, not just memory. There's some discussion in the literature about the kind of Alzheimerization of dementia. And obviously Alzheimer's is the most common form, but there are lots of other types too. And if you limit cognitive screening just to memory, you know, we can run the risk of missing other areas of concern and referring on. So, and I'll just show you this little table, which is from the survey I mentioned before, which is Dyer et al. This is what you guys are typically doing. And in terms of the screening tool, way out in front there is the MMSE in its own peloton. And coming in second, but quite far behind, is the MOCA. So let's take a look at the MMSE as a screener in GP practice. I'm sure all of you are kind of familiar / very familiar with this already. It does tick a lot of those boxes on the wish list. It covers a number of domains, not just memory. It doesn't address executive functioning, but it does address a lot of domains. It is acceptable, quick and easy. I guess one of the big downsides with it is that it does have a very big ceiling effect. So it's not that difficult to get 28, 29, 30 out of 30. So it's not very good at picking up more subtle kinds of cognitive issues or the mild cognitive impairment type of presentation. And that can be unhelpful. So a friend of mine recently, whose father went on to get a dementia diagnosis, felt quite invalidated, I think, by the fact that her father, who had quite a big cognitive reserve, kept scoring 26 out of 30 on his MMSE, and I think she felt the clinic weren't taking her concern seriously, because he was doing quite well. So it's not so good for those kind of subtle difficulties. Obviously, a big improvement was the publication of the standardized mini mental state exam by Willie Malloy and Timothy Standish in 1997. So there are kind of clearer instructions for scoring and administration, and that has increased the reliability for sure. The kind of typical cutoff is generally considered to be 24 for abnormality or likely dementia. There was an interesting study and a helpful one carried out by Cullen and colleagues involving some of our colleagues here in St James's Hospital, where they suggested 23 is probably a better cutoff for an Irish population. But they also kind of highlight the fact that locally derived norms are going to give you much better accuracy and much richer data than either published norms, which are probably going to be from the UK or the United States, or the traditional 24 cutoff point. And I'd really kind of second that. And thanks to our friends over at the Tilda study, they've used the MMSE and the MOCA as part of their tools in this study, with the result that we now have a table of normative data that's locally derived on an Irish population, reflecting Irish levels of education as well. So I'd highly recommend that you get yourselves a copy of this and print it up and stick it on the wall in your office, because when you do your MMSE, simply by looking at this table, you can immediately get much richer data. So for example, I've just highlighted there that a score of 25 there for an 80-year-old with a primary level of education is not particularly concerning. It's the 25th percentile, which is not really a problem at all. However, if it's an 85-year-old with a higher level of education, who's a college completer, that is very concerning, because that's at the level of the 5th percentile, and that certainly would be worth further investigation or referring on. 25 is above both recommended cutoffs there, but it would be a mistake to let that 85-year-old walk out of the office without doing something further. You're probably also aware of the fact, of course, that the MMSE is no longer free to use, and this caused a big furore a couple of years back. And especially for people who've been used to being able to just grab one and photocopy it. It does now need to be purchased, and it's purchased from the PowerInc website. It costs $99 for a pack of 50, so that's about €1.66 per copy. Up to you if you feel that's worth it or not. It's not very much money, and people are talking about, I think 2/3 of you were saying you might see 20 patients a year with memory complaints. It's up to you what you want to do about that. I mean, I guess there are people who just have the items in their head, and it's kind of a grey area if you can just do it from the top of your head. But if you're not keen on the MMSE, maybe you don't have the money to spend, what else is out there? Well, there's absolutely tons, okay? So I just looked at a review that Cullen and colleagues again had done in 2007 of screening tools that are suitable for GP practice. Because of course there are screening tools that are more geared for kind of population sampling, other things like that. But suitable for GP practice, they recommend sort of the MMSE as well as these other three, which are the modified mini mental state exam, also known as the 3MS, the cognitive ability screening instrument, and something called the SASI, the short and sweet screening instrument. The first two are both sort of variations on a theme of the MMSE. They take MMSE items and expand them, so you can score out of 100. And by doing so, the idea is that you're losing the screening problem, and you can get a more broad range that will allow for tracking more subtle cognitive deficits. The SASI combines a few items from other screening tests. But it only looks at, it actually excludes memory in its items, which I thought was a big omission, because that's often the thing that people will come complaining of. So that's what they recommended. And I also took a look at this document, which is downloadable from the ICGP website, and it's a really, really excellent resource. It's a kind of very short and concise document that gives all kinds of useful information about diagnosing dementia in general practice management, some of the topics that Sarah's covered as well. And it's free to download, and it's really excellent. So they looked at 3 well-conducted systematic reviews and came out with their kind of top 3, which is the GP COG, the mini COG, and the MIS. And they ticked a lot of boxes in terms of being practical, feasible, robust psychometric characteristics, and so on. So these are the 3 that they recommended. The GP COG, you may be familiar with it. It's an Australian instrument, and you can just go onto that website and it prompts you with the questions. It's very brief, just takes 5 minutes. And then it'll also prompt you with informant questions that you can ask. And then it actually takes you through to this sort of checklist of investigations that you can consider then completing. Some of them are pretty routine, and then some of them are kind of recommended only if indicated. So some of the more specialist things that might typically be carried out in a memory clinic like ours. The other one is the mini COG assessment instrument. Again, very brief, which is great, 3 to 5 minutes, but it does only look at 2 aspects of cognition, which seems a bit limited to me. And again, it's free to download there from the website. And the third one is the memory impairment screen, 4 items, 4 minutes, again, very brief, that's great. And it does seem to control for things like ethnicity and language biases. But there was a difficulty with that because it actually only focuses on memory. That's the problem there. So again, you're missing out on lots of other domains, okay? So I'm going to put in a kind of a plug for the MOCA here, and I'm hoping you'll see why after I go through this. So this was published in 2005. Again, I'm sure many of you have come across this. It's kind of similar format to the MMSE in that it's kind of a 30-item test. It covers a pretty wide range of domains there. So it's got executive functioning in there, which the MMSE doesn't have. Takes about 10 minutes. It's not a 5-minute, or it's a little bit more extensive than that. I think it is mentioned by in the Tony Foley paper, but he doesn't it's not one of the ones he recommends highly. It wasn't included in the Cullen review, but I think that's probably because that data was being gathered around the time this is being published. So there's the instrument, and it's downloadable from mocatest.org, which is just at the bottom of the screen there. It is more geared for the kind of subtler MCI kind of end of the spectrum. So it definitely doesn't suffer from the same ceiling effect that the MMSE does. So it's going to be more useful with kind of borderline concerns. Similar to so there are a couple of things then to mention about permission. So it is free people have permission to use it for clinical purposes. In health settings, that's absolutely fine. You need to get written permission if you want to use it in a research context. The website does say that training and certification is required by clinicians who use it, and that's a 1-hour training session, and it costs $150. There are some disciplines who are exempt. But the other thing is that there is an option, so you sort of log in and create an account, and then it'll take you through the pathway to either do the training or sign a disclaimer saying, I decline the opportunity to do the training, and I understand that when I complete the screening tool, I may not be doing it correctly, and so on. So that option is there, up to you what you want to do. The training is a one-off, so you can make your own decisions about that. On the MoCA website, it's not just the paper and pencil 30-item test. There's all kinds of things available there, including a version for a tablet. There's an app. There's lots of different languages available. There's adaptations for doing it over the telephone for people with very low levels of education and so on. So there's a whole suite of things available there. And also there are different versions for serial assessments as well. And again, thanks to the TILDA study, we have a rich data set here of normative data. So you can administer your MoCA, look at this table, which you'll have printed out and stuck on the wall in your office, and immediately see where somebody is going to lie, which is much richer than using a cutoff score, okay? So just to kind of sum up there, I think it's probably worth saying then, the MoCA is kind of highly acceptable to MCI population or people with sort of subtle enough changes in cognition and memory concerns who may find some of the tasks on the MMSE kind of ridiculously easy or insultingly so even. And conversely then, the MoCA may be too difficult and distressing even for people with more significant cognitive impairment, where maybe the kind of informant information is leading you to think this person may actually have established dementia. So it seems to me, I would say the ideal is to have both of them there, and then you can kind of pick and choose. And with the normative data, you have a really rich source of data there. Okay, so the other thing I wanted to talk about briefly is, what does normal cognitive aging look like? Okay, so we're going to just fly through a number of different domains here, and starting with intelligence. So intelligence, or IQ, is remarkably stable across the lifespan. There's an amazing piece of longitudinal research carried out in Scotland where they managed to get data from a kind of an IQ test that was given to children starting school in the 1920s and 30s in Scotland. They got a data set of 1,000 cases and managed to find 97 of those people who were still living at the age of 77, and they re-administered the same test to them. It was called the Moray House test. And there was a remarkable level of stability, and it's such a beautiful piece of longitudinal research, which is obviously very difficult to carry out. However, it is worth saying that, you know, intelligence isn't one thing. It's made up of a number of different factors, and there's a bit of debate about what they are, but largely there's a fair level of consensus. There are kind of two types of intelligence. One of them being sort of fluid intelligence, which is the kind of intelligence for solving kind of novel behaviors. How do I work my new washing machine? That kind of thing. And crystallized intelligence, which is intelligence for facts and learning, kind of experiences accumulated throughout the lifetime. And this actually, so the finding in terms of aging is that very reliably crystallized intelligence increases right into the 70s. Whereas fluid intelligence will start to drop off from early adulthood, from about the 20s or 30s, in fact. Now, there may be some slight differences in that with cohorts and more recent cohorts coming through and changes in the education system. But also it's worth knowing that, you know, fluid intelligence can respond well to sort of cognitive training type programs and increase as well, okay? So let's think about memory really quickly, which is the one people are typically going to come and complain about. Again, memory isn't one thing. There's lots of different types. So procedural memory is the memory for doing things. How do I ride a bicycle? Episodic memory is the one for events in your life. Okay, I remember my first day at school is my episodic memory. Prospective memory is the one for remembering to do things in the future, like I have to remember an appointment next week. Semantic memory is my kind of store of facts that I've gathered, like the names of all the capital cities in the world. And there's a specific subset there to mention, which is names of things and people. There's immediate memory, working memory, and so on. Some of these things kind of hold through until later life, and some of them decline. So things like procedural memory, semantic memory, and immediate memory tend to hold. The things that will typically decline as part of normal aging, and this isn't anything pathological, are episodic memory. So the typical one will be, listen, I can remember things from 40 years ago so clearly, but I'm not really sure what I did last weekend. That can be very much a part of normal aging. The prospective memory, having to use the calendar suddenly to keep track of dates and appointments. Working memory. And names is a big one. Lots of older people struggle with this and feel very embarrassed by it. And it's worth being able to kind of give some reassurance about that. Now, obviously, naming and naming things can be something that's also indicative of dementia, but if it's mild enough, it's probably more indicative of normal aging. And, you know, if you troll the internet, you'll find multiple versions of something like this, you know, a little kind of prompter that will help you work out if the kinds of cognitive problems somebody is talking about are more typical of normal aging or something that might be dementia. And this is just one that I pulled up, okay? But there are other domains as well that you may see people complaining about. So in the attentional domain, again, it's not one thing, but to sum it up in one sentence, older people have less attentional resource than in younger years, which means that they're going to be more distractible. They're going to find sort of dual task attention more difficult, like looking at my screen and looking at Zoom. That would be much more difficult for me as I age. They might be a bit slower to shift attention from one thing to another. So that, you know, trying to have a conversation when the telly is on becomes much more difficult later into life. Language generally is one of the kind of holes, although there'll be lots of maybe word finding or tip of the tongue type phenomenon, though again, kind of mild enough, and the forgetting of names. Physiospatial ability, which Sarah was mentioning, is obviously an important skill for driving. Basic aspects of this, like, you know, color perception, brightness, shape, are absolutely holes. They're as good as when people are younger, but more complex things like position orientation and rotation do become more challenging with age. And in terms of executive functioning, older people find thinking at an abstract level a bit more challenging. There tends to be an increase in sort of concrete thinking with aging, and a little bit less mental flexibility, the ability to switch quickly from one thing to another. So things like this task, which is the Tower of Hanoi, or the sort of trail making, which you find on the MOCA, becomes more challenging with age. So I'm hoping I've at breakneck speed addressed both of those topics. Thank you for listening.
You absolutely have. Thank you so much, Dr. Looney. Another excellent job of timekeeping there. Thanks for your really comprehensive and really interesting presentation. Both of them this evening. I'm sure all of our attendees will find them very useful. I think we just about have time to get in one question. I know there's lots of comments that have come in, positive comments and positive feedback on both presentations. But before we sign off, I'll just ask you one question, which is, how can I differentiate between depression and dementia? I don't know, Dr. Looney, do you want to take that, or was that Dr. Dwyer?
I'm sure we probably both have things. I mean, it is a big topic, and I guess very quickly, I suppose, you know, the issue is that lots of the features, you know, there are common features to both. So depressed mood, kind of psychomotor retardation, impaired learning and memory, and so on, you may well see in both. Some of it is about degree, I think, because if the difficulties are kind of milder, they may be kind of edging you more towards a depression type scenario. I think some of the key things are things like awareness and insight. So if somebody is kind of very keenly aware of memory deficits, maybe even hypervigilant about them, and can give you lots of detailed examples of the memory deficits that they're very worried about, that's probably more likely to be in the realm of dementia if it's alongside kind of low mood and lacking in energy and so on. Whereas if somebody is saying, "Ah, sure, I'm grand, you know, my kids are worried about me, but I'm fine, it's just my age," but the family are reporting there are deficits there, that may kind of nudge you more towards thinking about dementia. I mean, the types of cognitive difficulties that you see in depression are often around what are known as kind of effortful processing tasks. So things that require a lot of effort are typically the ones that are going to be impaired in depression. But in dementia, you're going to see different types of deficits showing up, okay? And I guess the other thing is kind of serial assessments, because, you know, if you're not sure, do a screener, treat, as Dr. Dwyer said, treat robustly. And don't forget psychotherapy for older adults. There's a really robust finding in the literature that older adults respond more positively to psychotherapy than working age adults. And it's something that maybe we don't always think about. And then assess again, reassess. And again, the MOCA has the multiple versions, so you can do the serial assessment and hopefully answer that question. Do you want to add anything to that, Sarah?
No, I mean, I think just to highlight what I said is, you know, I feel very strongly about robustly treating depression in older adults and the fact that it doesn't necessarily typically present like it does in younger adults. And the patients sometimes will actually present with what looks like cognitive blunting, cognitive slowing, and you're not quite sure what realm you're in. Is this kind of depression? Is this kind of memory problems? Treat the depression and see what you're left with. Get them back to baseline. And then if there's cognitive deficits that are kind of a comorbidity, yes, of course, that's something that needs to be addressed. But, you know, it's important that any potential pseudo dementia that's, I suppose, you know, coloring the clinical picture needs to be addressed in the first instance. And, you know, it's so, the thing about depression in older adults, it's so easy to treat. You know, the majority of cases, it's a melancholic endogenous depressive illness, and it responds to both psychotherapy and pharmacological interventions. And, you know, patients do recover. So it's really important that it's treated proactively rather than allowing you to sit on it and just, you know, kind of seeing how things go. Treat it in older adults, and, you know, treat it proactively and robustly.
Thank you. That's really helpful. Thank you to both of you for your time this evening. And thank you to our attendees as well. We hope you found this evening's presentations very useful. We'll leave it there, but just to say, when we sign off on this evening's webinar, you'll see a link on your screen where you can share feedback. We'd love to hear your thoughts. That'll help us improve future events. So if you do have 2 minutes, please do follow the link and share your feedback there. Today's webinar is part of a 6-part CPD accredited webinar, and the final webinar is going to take place next week on the topic of radical openness and emotional overcontrol. So you can register to attend that on our website, that's stpatricks.ie. And just a reminder there that CPD points from the ICGP will be sent on, the certs will be sent by email over the next few weeks, and a recording of the webinar will be shared on our website. So thanks to you all. I hope you enjoy the rest of your evening. Bye-bye, take care.